Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Archana Shrestha. She's an emergency physician. Today's KevinMD article titled Metric Shaming in Medicine and 3 Ways to Overcome It. Archana, welcome back to the show.
Hey, Kevin, it's so good to be here. Thanks for having me.
So we were talking offline. I think it's been 2.5 years since you last been on. Thank you so much for coming back. Now, for people who may not remember you, just briefly share your story and journey.
Yeah, my name is Dr. Archana Shrestha. I'm a board certified emergency physician. I'm a life and weight coach, and I'm also an author. And I'm the founder and chief wellness officer of the Mama Doc School, where I empower women in medicine and healthcare to achieve improved wellness and also overcome burnout or moral injury.
All right. So today's article, we talk about metric shaming. So first off, before you talk about that, tell us what that is.
Yeah, so metric shaming is a term that I coined. I think we've all sort of heard of the term fat shaming, right?
Mm-hmm.
And so I started to realize that there was this phenomenon happening in my experience, and also as a physician practicing in a community hospital, in an emergency department, and also to other physicians and clinicians, that we were being held to a lot of different metrics at work. I'm sure you can completely relate, Kevin.
Mm-hmm.
Things like RVU bonuses, patient satisfaction scores, rate at which we're prescribing things like antibiotics or controlled substances, door to doctor times, all sorts of metrics. And what I started to notice is that these are being posted in various different ways, sometimes sent out as a email to the entire, practice or all your colleagues, sometimes being posted in very public places in the doctor's lounge of like, these are all the surgeons and these are their infection rates, or these are all the OB doctors and with their name next to it. And here are their C-section rates. And so what I started to notice is it sort of started to feel like a shaming, like a public shaming of like, well, this is where so and so's at. And amongst colleagues, sometimes there was discussion of like, oh, did you see so and so's, RVU bonus? And like, oh, this person got the highest and this person got the lowest, and this person isn't producing enough, And so it sort of became this like, there's almost like the playground chatter
Yeah.
of
So
like who.
just to be clear, I think that almost sounds like high school, right? So there are literally, you've seen charts literally of doctors and their various metrics publicly posted. For instance, surgeons, they'll have their post-op infection rates posted and ranked in order based on their infection rate. Is that literally true?
That is literally true. I have seen that in doctors' lounges. I have also colleagues. I have a OB friend at a completely different hospital, a different part of the country, said, "Oh yeah, our C-section rates are posted with our names there." And in my own personal experience, we would get emails sent out of, "Okay, here's the RVU bonuses, here's the patient satisfaction scores." Nothing was anonymized, right? Just names next to all the data.
And why do you think administration would post it so publicly? Do you have any speculation as to what their motives could be?
Well, I mean, it would all just be speculation, right? Like I obviously don't know specifically what their thoughts were or intentions. I think it was very innocuous, though, most likely that they were just putting the information out there. These are now metrics that's on so many levels, between with Medicare, Medicaid, CMS, we are all being held to these metrics. It's very easy to capture these things now with the EMR, right? So we can collect this data. I think that the intentions most likely were benign. They weren't trying to shame anyone intentionally, but I think they just wanted to hold people accountable
Sure.
of, this is what the rates are and this is what the goal is. And usually that was how it was posted. Here's where everyone stands. Here's what the goal is and what we're trying to aim for. And I don't think it was ever really meant to harm anyone, most likely. Although I don't know for sure. Maybe there was. I can't really say that I know. I've never been an administrator. I've never been one posting any of these things. So I can't say for sure what it was. But, you know, what it led to, however, is what I can speak to. And I can speak to that, where it basically started to erode the confidence. I think in my particular case, it was eroding my confidence. And I felt like, well, wow, these are the only important things. Like, what about the fact that I did a great job with my patient, that I have really great outcomes, that I have incredible rapport with my patients, that many patients actually ask me if I could be their private physician, even though I don't have a private practice. That to me was always the ultimate compliment of, hey, I'm a hospital based physician and these patients are asking me, I wish I could come see you in a private practice. So, what about all of those things that were all these intangibles? And to me, those were the things that were really important in med school. And that was like the whole reason why I became a doctor is because I really wanted to take good care of patients and really help them in their moments of need. Yet here we were being held to all sorts of other metrics, which in many ways seemed random. Of course, some of them are important in patient care, but many of these things we don't always have control over.
So in the emergency department, and I know emergency medicine is a pretty metric heavy specialty, what will be examples of such metrics that you don't feel you have personal control over?
Yeah, for example, things like door to doctor times. So it was like things like the patient would check in at the front of the ER. And then if we were really backed up and couldn't get the patient back to the room in time, very quickly, the clock started the second that patient was in the waiting room, and
Yeah.
then they would get placed into a patient room, and then we would go see them. Oftentimes, we would get into the room to see them within 5-10 minutes of them being placed into a patient room. However, we were held to that whole time from the moment they hit the door from the waiting room till the time we saw them, and so it was like that clock didn't seem fair. Maybe if we started it from the moment they were placed in the patient room, that was when we could actually go see them in a private way, right? That respected their privacy. So there are things along those lines. Sometimes even things like patient satisfaction scores
Mm.
felt beyond our control because, some of the questions that were asked had to do with like, their wait time, which we didn't oftentimes have control over. And some of the other questions, how satisfied are you with your care? That is something that if a patient waited 3 hours, generally they're not going to be satisfied. No matter how great the care was, once they were seen, they're probably not going to be satisfied. Even things like, was your pain taken care of or addressed? And yes, while sometimes we could, and it was appropriate to be prescribing strong pain medications such as narcotics, in other instances, it wasn't. And in some instances, patients had perhaps a dependency or addiction to those and were kind of seeking those medications.
Mhm.
So it sometimes felt like an impossible task to try to cover. And on the one hand, we needed to be fast and quick and be seeing as many patients per hour as possible. And we were being measured on our RVU productivity. Yet on the other hand, we were being asked to keep our patient satisfaction scores up. And what we do know is that patients are more satisfied generally when they feel that they've been heard and listened to, which requires time. So
Mhm.
we can't just be in and out of the room in 2-3 minutes and expect that the patient will feel like they've been heard and understood and all their concerns were addressed. So it kind of felt like this big catch 22.
So when you saw all these metrics, did it subtly, or maybe not so subtly, change the way you practice medicine?
In some ways, yeah. I remember that we were brought in like a trainer who was like an outside consultant of, okay, here's the things that you can do to improve your patient satisfaction scores. So in a community setting, community hospitals, this was something that was really important because it determined how well received the hospital was within the
Yeah.
community, sort of like how many people possibly would go there if the patient satisfaction scores were high versus low. And so they wanted to really improve this metric. And so I remember being taught like certain scripts to say, things like, well, just so you know, you can expect to be here for, X number of minutes, or have we done a good job of addressing your concerns? So there were certain scripts that we
Mhm.
were asked to say, or like, oh, go get them water or a blanket, get them a snack if they're as long as they're not NPO. So it started to feel like at times I was becoming this waitress. And while there's no shame in getting a patient a blanket or water or a snack, I don't feel that that is beneath me by any means. It just felt kind of forced when we were doing it
Mhm.
with this end goal of trying to raise patient satisfaction scores. So, we were kind of trained in ways to try to improve these things. Yet there's so many other things going on in a busy emergency department where you're just trying to make sure you're doing all the right clinical things for your patients, yet alone doing these other things like, getting blankets and water.
So your Kevin MD article is metric shaming in medicine and 3 ways to overcome it. So let's talk about the latter part. What are some ways to overcome metric shaming?
Yeah, so, a lot of these things are things that I learned when I became a life coach, right? And so I think that there's many skills that we never learned anywhere along the way, but some of the key things that I learned is that first of all, we have to like make these numbers neutral. All right? So we can't make them mean so much about ourselves, like the number whether it's a high number or a low number or something in between, wherever you're ranking on this leaderboard, right? Like at the end of the day, the first step is to just make it neutral, not make it mean something good or bad, and just completely neutralize it. And from there, then the next step is to realize that you're always 100% worthy, that nothing can change your inherent worth. So, all humans, right? We're all born 100% worthy, and no number in our life can change our worth, whether that is our age, whether that is the amount of income
Mhm.
that we earn, whether that is the number on the scale, whether that is your step one board scores, whether that is, a patient satisfaction score, RVU number. So none of these things actually change your worth. And you are 100% worthy always. So none of these things can take away your worth. And then the third step is to decide with intention what you want to believe about yourself.
Mhm.
At the end of the day, the thing that matters the most is what we believe about ourselves, right? So I knew, of course, those first couple years of being an attending are kind of rocky. You're trying to get your clinical footing and just gain your confidence. But I
Mhm.
knew that I was a great doctor, that I had great outcomes, I had great rapport with my patients. I always did the right thing, what I believed was the right thing for the patient, right? And I was oftentimes staying late, taking care of things, making
Mhm.
sure they were all taken care of, right? So I knew in my heart that I was a good doctor and that I couldn't let these numbers, which were, they just change with day by
Yeah.
day. There's many forces in play that I didn't have control over. And I just intentionally decided that I would let those be what they were, let them be neutral, and not let those sway what I thought about myself, which I knew that I was a good doctor and I was always doing the best that I could with the resources that I was given.
Now, how difficult was that for you? Because, as you know, inherently, a lot of doctors from pretty much undergraduate on, or even high school on, very metric focused, right? Whether it's our grades or board scores. So, how difficult was that for you?
Oh my god, it was going against the grain, I'll tell
Yeah.
you for sure, Kevin. I mean, everything, that we'd ever been taught was to the contrary. I think, we are such high achievers as physicians, clinicians, like any of us who get into the medical field, healthcare, we have very high standards for ourselves, right? And also the stakes can be high,
Yeah.
right? Like we're dealing with patients' lives, an error could cause, injury or potentially even death, right?
Mhm.
And so we have very high stakes. So we hold ourselves to incredibly high standards. And so it took a long time to be able to get to that. But I think, there is a lot of different key skills that we never learn anywhere along the way in medicine that I think if we knew these things, that we would really be able to handle these things differently. And, it took me, being coached a lot
Yeah.
myself by others. It took me deciding to become a coach to really start to embody these things. And now I teach other people these things as well because they're really critical skills for us to sustain a career in medicine, especially given all the metrics that we are held to these days.
Do you sense that a lot of younger physicians, do they have the training in terms of how to cope with this onslaught of metrics, or is it something that you feel comes with coaching and experience?
I don't think that they do. I mean, sadly, we're seeing even residents with very high rates of burnout, right? And
Yeah.
I think that all of these things play into it, right? So I think that really we do need to make a shift within the culture of medicine. I've always described the culture of medicine as being very militaristic.
Yeah.
And I think we really need to, be more compassionate to others, to one another. I think those people in a position of power who are administrators, there's three things that I think they can begin to do to stop to stop this pattern of metric shaming. Like, I think first of all, they can stop posting these kinds of things
Yeah.
publicly and make it anonymous. And then number two, if there really is an area where you'd like to see improvement, just go ahead and give one-on-one feedback. Be compassionate. Understand that the environment too plays a huge factor, like like I said, as I mentioned, like, I'm always doing the best I can with the resources I've been given,
Mhm.
and I think that that's the case for almost everybody who's in medicine. Like, they really are genuinely trying to do the best they can with all the resources they've been given in a time of, short staff, being understaffed, at times of, different medications even not being available. Like, there's so many different factors that come into play. And I genuinely believe those of us who go into the healthcare field, we do really try our best and we are always trying to help as much as we can. And I think we need to really have a lot more compassion and learn how to give feedback in a different way.
We're talking to Archana Shrestha. She's an emergency physician. Her KevinMD article is titled Metric Shaming in Medicine and Three Ways to Overcome It. Archana, tell us some of your take home messages that you want to leave with the KevinMD audience.
Yeah, so I guess like my biggest take home message would be that, I mean, first of all, you are 100% worthy. And if you are feeling burnt out right now, like I know so many of us are, this is a huge problem right now. 53% of physicians are, 60% of PAs are feeling burnt out in a Medscape survey. But I want you to know that there's nothing wrong with you. You're not broken. I think you should definitely reach out, seek the help of a coach who can help you work through burnout and get you to a better place. And I know that so many of us healthcare workers are feeling overworked and overwhelmed, and like we have nothing left to give, but there is a better way where you can actually sustain yourself and not constantly self sacrifice yourself. And it really is going to take learning some key skills, some of which I described earlier, but definitely reach out, seek help. We don't want to lose any more of our colleagues to burnout. And, sadly, people do sometimes, as you know, Kevin, take their life. And so we don't want to see that. There's so many resources and opportunities for help. And I think my other big take home message is really for anybody in a position of leadership to really examine the ways in which we're doing things, create some systems to
Mhm.
really help ease the workflow for our clinicians and really be intentional about that because it is so key that we keep as many of us in this workforce. Otherwise we're going to have a massive shortage and patients will suffer at the end of the day, and all of us will be patients at one point too, so we need to make sure we are addressing this problem.
Archana, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks so much, Kevin. It's been a pleasure.